Dr. Minetta Liu is a research chair in the Division of Medical Oncology and an associate professor of oncology at the Mayo Clinic. Dr. Liu conducts patient-oriented research focused on two major areas: the development of clinically relevant molecular markers to allow for the most accurate prediction of treatment benefit and patient outcomes in solid tumor malignancies, and the development of novel therapeutics to improve survival in early-stage and metastatic breast cancer. Dr. Liu leads a collaborative effort to optimize and validate platforms for isolating and analyzing circulating tumor cells, cell-free DNA, and other blood components. Although her clinical expertise is in breast cancer, her liquid biopsy efforts are not restricted to any particular malignancy. Dr. Liu leads several collaborative multi-institutional clinical trials through such mechanisms as the Alliance for Clinical Trials in Oncology and the Translational Breast Cancer Research Consortium. The investigational agents explored in these studies have the potential to improve outcomes in all settings of breast cancer. This includes a series of phase 1 trials with oncolytic measles virotherapy as part of the Mayo Clinic Specialized Program of Research Excellence in Breast Cancer. Welcome, Dr. Liu. Please proceed.
Thank you very much. I'm not sure who wrote that bio, so I'm sorry it was such a mouthful. So thanks, Christine, and thanks everybody who's joining today. It's my pleasure to give a little bit of an update from the San Antonio Breast Cancer Symposium in San Antonio, Texas this past December. I was tasked with selecting some abstracts to present, and I thought I would give a little bit of an introduction to put those abstracts in context. So to talk about basically the approach to treating metastatic breast cancer, because I think that will help in some understanding some of the abstracts that I've selected. These are just my disclosures. I do a fair amount of research. None of this funding comes to me. It all goes to Mayo to support the work. So to put this in context, we're focused here on advanced or metastatic breast cancer. We're not doing as well as I'd like, because I always tell everyone I want to put myself out of a job with this research, right? I don't want to have to be administering therapy because there should be no metastatic breast cancer. But for right now, we do have to deal with this form of breast cancer. But we're doing better and better with each decade. And in fact, our advances are happening even more quickly now than we could ever imagine. Again, it's just never fast enough. But if you look at the figure on the left, it's looking at drug development dating back to the 1950s and key FDA approvals for breast cancer at different decades. And just seeing that, again, more and more agents are available. But when you look at the curve on the right, what it's looking at is survival over the course of time broken down by decades. And you can see that with each decade, we are doing better. So even though an individual clinical trial may not demonstrate an overall survival benefit with a new drug, when you take everything together and look at all of the advances, the new therapies, the new biomarkers, every advance that we are making, and you take that in one big package, we are doing better. And that's the key message. So the challenges, we know unfortunately at this time, all patients or almost all patients with metastatic breast cancer are expected to develop progressive disease. So that means that at the time of initial presentation with metastases, a therapy is started. The question we always get is, how long am I going to be on this? You know, is this going to work forever? The expectation is that at some point in time, treatment does need to be changed. And that treatment change could be because the disease has progressed, meaning something got bigger or a new spot developed. Or we also have to importantly remember that our therapies may need to change because of side effects or toxicities. So at any individual point in time for any individual patient, we don't have the ability right now to individualize the selection of the best treatment choice at disease progression. We want to get there, and that's where these advances in genomics and biomarkers are going to help take us that big leap forward. The things right now that we have to consider at each point in time when making decisions about treatment changes relate to both the tumor as well as, most importantly, the patients themselves. So with respect to tumor biology, the assessment of estrogen receptor or ER, progesterone receptor, meaning PR, and HER2 status. We take into account the extent of disease, the sites of involvement, the disease-free interval, meaning the time between initial early-stage breast cancer diagnosis versus the presentation of metastases, as well as the response to prior therapy, what worked before, what didn't work before. And again, the very important patient-related factors of preference, IV versus oral, weekly versus once a month, schedules, different types of side effects that we can never predict if they're going to occur, but if they did, we all have sort of different perspectives about how that would impact our lives. And comorbidities, meaning pre-existing medical issues that may say a certain drug with the potential for these toxicities should be avoided in a particular situation. The goals of therapy will vary depending on who you're asking. So with respect to clinical trials, the key endpoints or things that we're looking for to say that a new drug or a new drug combination is a success is the rate of response, meaning what proportion of patients who participate in the study achieved some shrinkage or even disappearance of metastatic lesions. How long did that benefit last? Other endpoints can also include time, so time to progression, TTP, time to treatment failure, which is TTF, progression-free survival, meaning how long did it take before the disease got worse again, and importantly, overall survival. We can't forget quality of life because there are pros and cons to everything, and an extra month, if it's an extra month in the hospital, maybe that's not the benefit that we're looking for. Safety and toxicity are always investigated in clinical trials as well. From the perspective of patient goals, extending survival, but we also have to think about the toxicities. So again, hair loss, fatigue. I always try to think about the fact that with metastatic breast cancer, the major goal here is to acknowledge the disease, incorporate therapy into it, but allow us all to live through it, right? So extending survival, yes, but the everyday things to allow us to work, take care of our families, enjoy our lives. And so those different side effects mean different things to people. Hair loss for many is an absolute I need to avoid, or can we do anything to avoid that? Certainly we want to do everything we can to minimize disease-related symptoms, and in terms of quality of life, things that are also important to consider that aren't always considered, the need for IV access. So do we have to have a port placed? Or again, this frequency of visits, weekly, once every 3 weeks, are there everyday components of the care? So in the effort to try to, again, maximize quality of life and maximize treatment benefit, there is always this question, particularly in hormone receptor positive breast cancer, endocrine therapy or the anti-hormone drugs, the tamoxifens, anastrozole, letrozole, exemestane, fulvestrant, those therapies that are targeting the estrogen receptor or affecting how estrogen interacts with cancer cells, that versus chemotherapy. Because we would like to avoid chemotherapy as much as possible. And the question is, should we always err on the side of endocrine therapy in hormone receptor positive breast cancer, or are we potentially doing harm? So one group looked at 8 very large randomized clinical trials and pulled all of that data together to get a sense of simply erring for endocrine therapy versus chemotherapy. Did that have an impact overall in terms of how well people did? The caveats to this were in the trials, in most of the situations, hormone receptor status was not necessarily reassessed. So that question of endocrine therapy in someone who has hormone receptor negative breast cancer wouldn't have been expected to have benefit. They didn't see any trends in terms of age, menopausal status, or the sites of distant metastatic disease. What this table represents are just the different kinds of outcomes that they were looking at. And essentially the bottom line is, for hormone receptor positive metastatic breast cancer, unless a patient has severe symptoms, or something that is about to cause imminent medical problems from the cancer itself, endocrine therapy should always be considered as first-line therapy before chemotherapy. So that gives us confidence in the setting of hormone receptor positive disease that we should think about endocrine therapy, and we do. The question, and again, this caveat, is about the hormone receptor status. So what we're increasingly recognizing is that hormone receptor status that's determined at the time of original diagnosis of breast cancer doesn't always mean that the breast cancer is going to stay hormone receptor positive. And so that's what we call status conversion. And just as an example, this was looking at about 1,000 patients who had a history of early stage breast cancer, had a breast cancer recurrence within this 10-year period, and there were tissue samples available both at diagnosis and then at the time of recurrence. So those are paired samples. And then the hormone receptors and HER2 status were all repeated to compare between the two. And so what you can see in the table is that there's a rate of conversion for the hormone receptors. For hormone, about 25% of the cases, hormone receptor positive primaries were then paired with hormone receptor negative recurrences. The other direction, in other words, going from negative to positive, is less common, but can also be seen. And so this is the argument for the growing trend that at the time of recurrence to consider repeating a biopsy, because as you can tell from what we just discussed on the previous slide, the hormone receptors do make a big difference in the types of therapies that we can recommend. When looking back at those patients who had a conversion of the hormone receptor status from early stage disease to metastatic disease, they tended to be in patients who had already received endocrine therapy. In other words, hormone receptor positive breast cancer at early stage got tamoxifen, or aromatase inhibitor, and then ultimately later, if they recurred, again, some of those patients had disease that came back as hormone receptor negative disease. And there was a sub-study looking at some patients who, with metastatic disease, had biopsies done in sequence. In other words, a biopsy at one point in time before starting therapy, and then maybe months, years later, another biopsy done for different reasons. And again, there can be conversion down the line as well. So not saying that every time we see something we need to biopsy it, but we have to keep this in mind because it is so relevant to our treatment decisions. And this is just about the hormone receptors. This is just showing that in terms of survival, it does appear to make a difference if there is conversion, but what you have to take into account here is that the likelihood is that if there was conversion and it wasn't recognized at the time of treatment, then maybe the patient wasn't on the right therapy. And so it's not necessarily just the observation that hormone receptors changed that had the potential to affect survival. What you see on the left are both local and systemic relapses, meaning the breast cancer coming back in the same area it was before or distantly. On the right is just focusing on distant disease, and they're pretty similar. The other question that always comes up specific to chemotherapy is, do we do one drug or two? And I bring this up because combination therapy in this day and age means something different. So with respect to combination chemotherapy, we do not have evidence that combining multiple chemotherapy drugs or creating chemotherapy regimen is in fact superior to using those same drugs that would be in that one combination regimen. In other words, using those same drugs but in sequence. So the argument is, as long as someone got all of those drugs, they're going to do just as well, whether you gave them all at once or you gave them one at a time, and that those changes from one to the next therapy were indicated because of progression of disease or because of side effects. The times that we think about giving two drugs or two chemotherapy drugs at the same time is because the two drugs together tend to give us a bigger response more quickly. But it comes at the cost of potential toxicities. And so again, just what we have to keep in mind. And then what's on this slide are the biologic targets. So this is where we are now, right? So we have hormone receptor status, we've got HER2 status, we see that things can convert. And now we're in this age where we're looking at more and more targets or more and more pieces of the machinery of a cancer cell that we believe we can target. so how are we going to identify that target? Do we know that it's there? And the second question is going to be, how is that target changing over the course of time? At this point in time, we're excited about the new drugs that are being developed and trying to understand that they have a role in breast cancer, but then subsequently we're going to need to better understand who, when we should be giving these agents. And so this very complicated figure is just illustrating the fact this isn't even all of the targets that exist, all the different pieces of the machinery of the breast cancer cell that we can potentially affect. The other thing we have to recognize is it's not just those pieces of the machinery about the breast cancer itself. We realize that there are more than just hormone receptor positive and HER2 positive or negative breast cancers. And so this figure is just illustrating the molecular gene signatures as we've all now come to understand them. This was based on looking at the DNA of cancer cells and dividing cancers into the HER2 positive, luminal A, luminal B, and basal-like breast cancers. I always want to remind people that this subtyping is based on a type of test that we don't routinely do in breast cancer. So this helps us to understand biology and science, but it's not yet directly applicable to patient care because it's not what we're routinely doing in testing. From the research perspective, with those different subtypes, we realize that there are even more subtypes of the subtypes, not to confuse things, but this is the reality. So this is using subtyping of patients who have hormone receptor negative, HER2 negative breast cancer, which under the microscope would look completely the same, and from a pathology report would look similar. But again, looking at the mechanisms, what's making that tumor tick, trying to understand all of these different elements, we can break down again into different subtypes, and then that can translate into different treatment approaches for those different subtypes. So this just leads into the abstracts that I've selected for from the San Antonio Breast Cancer Symposium. Wanted to focus on different classes of drugs, trials that look like they are going to help us to improve therapy in the nearer future. I didn't select any that were purely animal studies or mechanistic studies because for me, near and dear to my heart is bringing this back to the clinic as quickly as we can. So for PARP inhibitors, just to give you a sense of what they are, it's a term I think we're all hearing more and more. So PARP is a key regulator of DNA damage repair. So DNA, or the coding material of all of our cells, is always undergoing potential changes, and if errors happen, right, we hope that those cells basically die. So those errors can't cause us problems, or that we have mechanisms to help repair those that area of damage so that the damage doesn't perpetuate and then cause problems later on down the line. So these PARP inhibitors bind directly to the sites of DNA damage and produce these large PARPs basically, and they can be differentially upregulated in different types of cancers. The EMBRACA trial was presented at the San Antonio Breast Cancer Symposium. EMBRACA is a phase 3 study that focuses on talazoparib, which is a PARP inhibitor. It's an unusual PARP inhibitor because it inhibits this enzyme PARP in two ways. Most of the PARP inhibitors focus only on one potential avenue, and so having sort of that dual inhibition, the theory is that it should have potentially more efficacy. And so those two approaches are synthetic lethality in hormone receptor, homologous recombinant deficient tumors, or lethality that's not restricted to hormone deficiency. And basically that says for synthetic lethality and homologous recombination deficient tumors, those are more the potentially the BRCA1, BRCA2 type tumors because they have that deficiency. The question though is then, can talazoparib, because it's not restricted to that deficiency, could it then have a broader catchment in terms of potential benefit? And so this figure at the bottom is just illustrating how that potential repair is done. So the EMBRACA phase 3 trial looked at 431 patients. It was a randomization between talazoparib, the PARP inhibitor. It was 1 pill a day. And the comparator was the physician's choice of therapy. So these were patients who would be going on to chemotherapy if they weren't participating in this study. And if they were to participate in this study and were randomized to the physician's choice of therapy, the choices were one of 4 chemotherapy drugs: capecitabine, eribulin, gemcitabine, or vinorelbine. And that had to be declared as the patient was going on the study. In terms of eligibility, this was for patients with locally advanced or metastatic breast cancer who had received up to 3 prior lines of chemotherapy for metastatic disease. All patients had to have HER2 negative breast cancer. They could have hormone receptor positive or negative disease, and they all had to have a documented germline mutation in BRCA1 or BRCA2. In other words, a hereditary predisposition based on one of these 2 genes for having developed breast cancer. The primary endpoint for the study was progression-free survival based on central review, so we tried to take the bias away from the investigators who always want to think more positively. The belief is central review is more objective. The median follow-up was 11.2 months. The median age for patients participating in this study was 45 to 50 years. Importantly, it did include patients who had a prior diagnosis of brain metastases from the breast cancer, so that had been treated and had been stable, so was not the primary reason for necessarily going on the study. About 45% of these patients have hormone receptor negative, HER2 negative breast cancer. There were 45% of patients who had a BRCA1 mutation. The other 55% had a BRCA2 mutation. And 3/4 of these patients had measurable disease, meaning something that we could measure either on exam or typically more frequently on an imaging study like a CT scan or an ultrasound MRI. And that would allow us to look at response rates or the percent of patients who had tumor shrinkage. And to look at the results, so progression-free survival of talazoparib versus the physician's choice of therapy was 8.6 months versus 5.6 months, which was statistically significant. If you looked at the response rates, so that's only in those patients who had measurable disease, and that includes either the complete disappearance of all visible or acknowledged tumor lesions, or simply shrinkage of. It was very significantly different between talazoparib and the physician's choice of chemotherapy, 63% versus 27%. And the duration of response, the length of time that a patient was on the drug before they had to come off because of disease progression, again, statistically significant differences of 5.4 months versus 3.1 months. And importantly, we do see this more and more in our clinical trials as a formal evaluation of quality of life, QOL, and this was using a global health score. And the score improved in those patients who were on talazoparib. For those patients who had received chemotherapy on this study, their quality of life scores decreased, so became into the negative, and that was a very statistically significant difference. Most of these patients had received chemotherapy before going on to the study. And this basically reflects the fact that talazoparib is a well-tolerated drug, and the fact that it's oral certainly can help in terms of improving quality of life as well. So the next class of drugs and the next abstract that I selected, CDK4/6 inhibitors. So just to give you a sense again of what the agents are trying to do. So CDK4/6 is an important regulator of cell cycle control. What that means is as our cells are dividing, whether there are cells that we like because there are normal cells or the cancer cells that we're trying to interrupt, these cells are always going through a cycle where they're, in order to divide, replicate, and make more of themselves. And in the case of our normal cells, we want that to proceed as normal. What happens in tumors is that cell cycle becomes very erratic and uncontrolled so that those cells can continuously divide. So the hope is, using these CDK4/6 inhibitors, that we can inhibit and sort of derail the cell cycle for the tumor cells specifically. The MONALEESA 7 study is a phase 3 clinical trial looking at one of the CDK4/6 inhibitors, ribociclib, versus placebo in patients who are receiving tamoxifen or an aromatase inhibitor, a nonsteroidal aromatase inhibitor, meaning Femara, letrozole, or Arimidex and anastrozole. Importantly, this is one of the largest trials in premenopausal women. So all women who were eligible for this study were pre or perimenopausal. And in order to go on to the study, because our standard first-line therapy for premenopausal women, at least by guidelines, is to consider ovarian functional suppression in combination with tamoxifen or a nonsteroidal aromatase inhibitor. So that everyone got, again, in the randomization or the comparison was ribociclib versus placebo. To put this in perspective, palbociclib or Ibrance, which has already been FDA approved, is used in the first-line setting in postmenopausal women. We don't have a single study focused specifically on premenopausal women with that particular agent. So there were 672 patients who participated. Again, this is in advanced breast cancer. All patients had to have hormone receptor positive, HER2 negative breast cancer. They had to be pre or perimenopausal. And this is a first-line therapy study for endocrine therapy, so no prior endocrine therapy for advanced breast cancer. They could have received endocrine therapy after a diagnosis of early-stage disease, but it at least had to be a year before the metastases were diagnosed and consideration for this study. And some patients did receive chemotherapy before going on to the study. The eligibility criteria had a limit of 1 line of chemotherapy. The primary endpoint was progression-free survival. The median follow-up is 19.2 months. The median age, 43 to 45. So there were some very young premenopausal women, but again, this is the median as presented. About half the patients had visceral metastases, meaning metastases that were not just in bone and lymph nodes. 40% of the participants had stage 4 disease, meaning they presented with metastatic breast cancer as their initial presentation of breast cancer. And 14% had received prior chemotherapy before entry into the study. So looking at ribociclib versus placebo, and again, every patient received either tamoxifen or a nonsteroidal aromatase inhibitor with gaserelin, so that's in the background for all patients. But breaking down between those that received ribociclib versus placebo, for progression-free survival, very significant difference between 23.8 months versus 13 months. CBR stands for clinical benefit rate. What that means is the proportion of patients who either had stable disease, here it's stable disease at 6 months, or they had some tumor shrinkage that qualified as either a partial response or a complete response. And again, there was a difference, 79.9% versus 67.3% in favor of the CDK4/6 inhibitor, ribociclib. And if you looked at, they used formal tools to monitor symptoms during the course of therapy. One of the symptoms they focused on was pain. So if you looked at the time it took for symptoms to develop or for patients to start to feel worse because of their disease, it was not reported with ribociclib, meaning that people continued to feel well during the time period that these questions were being asked. For placebo, about 21.2 months for statistically significant symptom deterioration. So what this suggests is stability, I always say, is a good thing too. And if we can maintain stability or get response, and importantly, maintain the absence of symptoms or the progression of symptoms, that is a significant outcome as well. And then lastly, you can't give a presentation these days about breast cancer, any cancer, without talking about immunotherapy, so the checkpoint inhibitors. So the checkpoint inhibitors, or the checkpoints, are the PD-1 and PD-L1 interactions. And what we know now is that inhibiting this pathway helps to reactivate or these T cells, essentially reawakening the immune system. And the entire premise of immunotherapy is essentially trying to wake up our immune systems to attack specifically cancer cells. So what this figure is illustrating is essentially so PD-L1 is the blue, sort of looks like a rocket, and the green is PD-1. and to see how these interactions can happen and essentially turn on the immune system or turn off the immune system. So PD-1 is the receptor that's on T cells, so that's on our normal immune cells. And PD-L1, which is what it binds to or interacts with, is on immune cells, but importantly on tumor cells as well. And it's for that reason that in some of these trials of checkpoint inhibitors, you'll oftentimes hear PD-L1 positivity or negativity. And that's essentially reflecting whether or not this PD-L1 protein can be detected on the tumor cells themselves. Because the question is, to use an inhibitor of this pathway, do we have to demonstrate that that protein PD-L1 is in fact present on the tumor cells? And that's an area of much research now and not clear for breast cancer if we should be testing that routinely. And this cartoon, again, is just illustrating how the different drugs that are out there in terms of research, some of these trials, some of these agents are already FDA approved in other malignancies, where they interact in terms of affecting these different interactions. On the left is ipilimumab, which is a CTLA-4 inhibitor, has not been studied widely in breast cancer. It was one of the earlier checkpoint inhibitors. The focus now is what's on the right side of the screen, the PD-1 inhibitors and the PD-L1 inhibitors. The PD-1 inhibitors, pembrolizumab and nivolumab, are both FDA approved for melanoma, non-small cell lung cancer, renal cell cancer, bladder cancer, and lymphoma. So we're looking for the right patient population in breast cancer to invoke these therapies. The question is, should we be using this as a single agent, or do we need to be combining it with other drugs? And so that is the area of active research ongoing right now in metastatic breast cancer. And towards that end, PANACEA is an early stage study, a phase 1b/2 trial that's looking at the use of pembrolizumab, which is marketed as Keytruda, in combination with trastuzumab, specifically for patients with HER2-positive breast cancer. So the question is, in the setting of HER2-positive breast cancer, where trastuzumab has been given and has likely offered benefit, but unfortunately no longer offers benefit, can we add pembrolizumab in that setting to reset things, right, and to then lead to further response and treatment benefit? And there was an effort in the study to separate patients who had tumors that were PD-L1 positive versus PD-L1 negative to try to get at that question as to whether or not we should in fact be testing for this to make decisions about whether or not pembrolizumab would be helpful. This trial focused on patients with advanced breast cancer. They had to have a tumor biopsy with tissue that was available at least within a year of going on study. So a biopsy was not necessary to go on study, but there needed to be tissue to do the testing for PD-L1. There were no limitations on prior therapies. All patients had to have HER2-positive breast cancer because trastuzumab was a mandated part of the study. All these patients had to have evidence of progression of disease with trastuzumab or TDM1, which is trastuzumab linked to a chemotherapy agent. And all patients had to have measurable disease because the primary endpoint was looking at responses or objective response rates. The median follow-up was 13.6 months. Over half of these patients had hormone receptor negative disease. Again, all patients had to have HER2-positive breast cancer. Although the eligibility criteria mandated only prior exposure to trastuzumab, the great majority, over 80% of patients participating in this study, had received subsequent types of HER2-directed therapy. Those would include pertuzumab, which is marketed as Perjeta, or again, TDM1. And these are the results that are broken down by PD-L1 positivity. So the phase 1b portion of the study was a very small study looking at dose and toxicity, and then the larger portion of it was the phase 2 study. But if you look at the PD-L1 positive patients across both of them, the response rates were about 15, 16%, and the benefit rate, again, stable disease plus the responders, set 25 to 17%, depending on which patient population you looked at. For patients who had PD-L1 negative breast cancers, at least in this study, and there were only 12 of them, there were no responses that were demonstrated. for progression-free survival, which was only looked at in the phase 2 study, so in the larger portion of the study, although it was statistically significant, there were not great differences in progression-free survival between PD-L1 positive versus negative tumors, 2.7 months versus 2.5 months, and for overall survival, though there was a significant difference, 16.1 months versus 7 months for those patients who had PD-L1 positive breast cancer on this study. So this suggests that there is a potential role for pembrolizumab with trastuzumab in HER2 positive breast cancer, and the efforts are to move this earlier in therapy because most of these patients were quite heavily pretreated with multiple lines of therapy before going on to the study. And what we are learning more and more in breast cancer is that with each type or line of chemotherapy, these breast cancers become less and less immunogenic, meaning less likely to wake up the immune system by themselves. We want to use potentially these drugs earlier in the course of therapy to have the greatest effect. And so a lot of these trials are ongoing now. And that was it for the formal presentation. I wanted to make sure I left time for questions, either about these abstracts, anything about metastatic breast cancer, anything that was presented at San Antonio. I really thank again everybody for attending and for inviting me to participate.
Thank you, Dr. Liu. So we have some questions here for you. What do you think are the major research challenges that are preventing improvements for long-term survival of metastatic breast cancer patients?
I don't know if we can necessarily. I actually would argue that we are. That it's not trial structure, any one fact that we're not, in fact, being prevented from making overall survival benefits. If I'm answering that right, let me take a step back. When you look at a clinical trial, a single clinical trial in metastatic breast cancer, and you look at overall survival rates, that overall survival is calculated from the time an individual participated in the study until the time they passed, but it doesn't necessarily take into account everything that they did between finishing that study and then succumbing to disease, right? So it's hard to truly use overall survival as a metric for benefit for a certain drug in a certain trial, because unfortunately or fortunately, we don't control everything that happens after participation in the study. And so that's why I started this presentation by talking about the fact that we are improving overall survival. But if you look at all of the trials that led to those FDA approvals, the great majority of them did not, for that specific study, demonstrate an overall survival benefit. So the greatest difficulty is, in fact, trying to look at overall survival and using that as the be-all, end-all, right, in terms of defining the potential benefits of therapy. And gratefully, the metrics and the end points that we're using in clinical trials to prove benefit, to get drugs out there on the market so that we can use them, and not just in clinical trials, but as part of our standard of care. That's where looking at response rates, progression-free survival, those types of things are helping us to get approvals and get drugs out there more quickly.
Thank you. Another question is, do we know what causes the hormone receptors change over a period of time?
We don't know I don't know if there's an exact mechanism. I mean, nobody knows. The likelihood is that it has to do with tumor heterogeneity. So tumor cells, as a tumor is developing, there's a single cell that's abnormal. It could be it's a hormone receptor positive cell. It starts to divide, replicate, make more of itself to make the actual breast tumor. And then at some point, some of those cells go somewhere else. And they then set up a site for metastatic disease, and then again can divide and make another site of actual metastasis. As these cells are rapidly dividing, they make errors. And it's possible that they're both hormone receptor positive and hormone receptor negative breast cancers within those tumors. or that when a cell goes to a different part of the body, for whatever reason, it's an environment that it wants to, it's more likely to survive if it's hormone receptor positive or negative. And you have to imagine that we put external pressures on all of this because we're applying therapies. So for a hormone receptor positive breast cancer, we give an anti-hormone drug. Well, if a breast cancer is trying to survive, those cells that are most likely going to survive are the hormone receptor negative cells, because the hormone receptor positive cells presumably got squashed by the existing therapy. So there's no one single answer, but it is a phenomenon that we now truly recognize. And there are multiple explanations for it. But again, the question is, at the here and now, when we have to make a treatment decision, how best do we make that when the hormone receptors and the HER2 status are vital to helping us make some of these treatment decisions?
So someone's asking if men were included in any of these trials, and if no, why not? And we know that men with metastatic disease feel very underrepresented in the clinical trials.
Thank you very much for that question. It's so true. So men were not formally excluded, but they were not represented because there's such a rare population of patients. So again, they weren't formally excluded. The difficulty, what we learn more and more as groups, there's a large effort between Europe and the United States to work together to help understand the biology of male breast cancer. And there have been some publications about this. What we're recognizing now is that even if the breast cancer itself, looking under the microscope, looks the same, how it behaves in a female versus a male is slightly different. And the difficulty for us as clinicians taking care of patients and researchers trying to do with these studies is that the number of male breast cancer patients is so small, and then hormone receptor negative, you start breaking it up by different types, it makes it even smaller. So to do a clinical trial with our traditional endpoints is impossible, specifically in the male population. So again, this is where we're thankful for collaborations and groups between the U.S. and Europe for trying a concerted effort to try to create a big enough pool of these patients. I wish no breast cancer patients existed, but a large enough pool of male breast cancer patients to then conduct some meaningful studies to answer these questions.
Can you talk a little bit about the treatment of metastatic triple-negative breast cancer? Someone is just asking, is there any hopeful news coming out of San Antonio?
I think there's definitely hopeful. I think there's hopeful news for all subtypes of breast cancer, including hormone receptor negative, HER2 negative breast cancer. I think we've always known that this entity exists, right? It's just something that more and more we're becoming aware of because of molecular testing, and because of now we have these additional molecular subtypes that break down not just hormone receptor negative, HER2 negative, but basal-like breast cancer, et cetera. So the promising thing is the ability now to conduct trials not in all comers, but the focus on specific subtypes of breast cancer. So we have, trials specifically for hormone receptor negative, HER2 negative breast cancers, and oftentimes those trials unfortunately require an additional biopsy, but that biopsy is to help look for additional targets that we don't traditionally see in all of breast cancers. So the checkpoint inhibitors, I know the abstract I presented was in HER2 positive breast cancer, but those are agents that look like they have particular benefit for patients who have hormone receptor negative, HER2 negative disease, because that tends to be more of an immunogenic type cancer. In other words, one that is more likely that our immune systems might be able to recognize and to get rid of. And we have evidence in some early stage studies where these drugs do have potential for huge benefit. So again, no FDA approvals yet, but hopefully coming down the pike. I guess that's the long answer to saying that we are understanding more about the biology of this subtype, and trying better to target that biology specifically.
Thank you. So there are a couple of questions about if there's any evidence about progression-free survival when lowering the dose of Ibrance.
I think this is probably stemming for the fact that there's a significant proportion of patients who do require a dose reduction, I guess. So with palbociclib, with all of the CDK4/6 inhibitors, one of the major side effects or toxicities is that it can cause neutropenia or the white blood cell count to go down. The good thing is that although it goes down, very, very rarely is there any consequence to that. And the biggest consequence is then febrile having a fever in that setting or then having an infectious complication. So it's something that we observe on blood work, but gratefully doesn't have a large consequence other than the need to reduce the dose of the drug or take a break from the drug. And people, we all, I think, just human nature worry if you're going to hold something but you should have been taking it every day that it's not going to work as well. I will say that in the clinical trials that were done to lead to the approvals of these agents, that there were very strict guidelines, which we now follow in clinical practice, to reduce the doses or take breaks of therapy, and yet we still saw these very significant benefits. So I look at it as our bodies telling us that that's too much for us, and we need less, and it's going to be the same for any of the chemotherapeutics that we use, where in some cases we do have to reduce those doses. That the ability to continue to take the medication at a reduced dose or taking a break and being able to resume and stay on track is of greater benefit than trying to tough it out and then having to take a much longer break because you have to recover from those side effects. Because it's the exposure of the tumor to the drug that is a huge part of the benefit of that drug.
So there are several questions about blood biopsies and liquid biopsies. So can you tell us how, are they going to be standard practice anytime soon for metastatic breast cancer patients?
So they were for a little bit of time. So liquid biopsy is sort of an umbrella term for using some factor that can be picked up in the bloodstream as a marker for the tumor itself. That's basically what liquid biopsy means. And as an umbrella term, it covers things like circulating tumor cells, cell-free DNA, exosomes, are the ones that are thought of most commonly. It doesn't cover the CA15-3, CA27-29, CEA, the traditional quote-unquote tumor markers that have been used in breast cancer. Those are proteins that are picked up in the blood. And they've actually never been endorsed officially by guidelines because there's never been evidence that acting on those tumor markers was in fact going to improve outcomes. And that's where we are with the existing liquid biopsies, the modern day ones, the circulating tumor cells, cell-free DNA. My comment before about how these were standard of care. So circulating tumor cells, there was one technology that the FDA has cleared that was used and was billable to insurance companies for several years. And despite a wealth of evidence that suggests that counting these cells in the bloodstream and seeing them in the bloodstream correlated with how well patients were going to do from their cancer perspective, there has not yet been a demonstration that if you acted on that result, that it in fact improved outcomes. And so for that reason, it's not in guidelines, it's not a standard of care, and why insurance companies in fact stopped covering it, because they said, look, you have your tools that we know help, like scans, et cetera. You haven't proven that this blood test really will positively impact outcomes, meaning survival in patients. And so those studies are ongoing now. To bring it back to the San Antonio Breast Cancer Symposium, there was a presentation about circulating tumor cells It was in the early stage setting, which was yet another study that demonstrates that if you see these cells, those patients if you saw those cells after someone had finished surgery, finished their chemotherapy or anti-hormone therapy for early stage breast cancer, if those cells were detected, that patient population was more likely to experience a recurrence. The question is, though, if you saw it at that point in time, if you acted on it, would it have made a difference? And in fact, those studies are coming to the fore now, because that's what we need, those tools, right? We need to know as early as possible when we should make a change in treatment. I would rather not wait till something changes on a scan. If I could find a signal in the blood at 4 to 6 weeks after starting a new drug, why waste time and give people toxicities from drugs that ultimately aren't going to benefit? The same would be true in early stage disease, right? We'd like to be able to identify those patients who truly, quote unquote, need some alternative form of early stage therapy beyond our standard of care.
Thank you. Yes, so there are several questions about CDK4/6 inhibitors. So if treatment fails with one, can you move to another?
That's the $1 million question.
Exactly.
Because we now have multiple drugs on the market now. And the other question, too, is if there's an individual who was treated with, say, palbociclib, right? Should it be treated like the HER2-positive patient with Herceptin or trastuzumab? Is this something that we should really stop, or should it just always be ongoing in the background with endocrine therapy? And I know I keep saying this, but there's studies that are ongoing. I wish I had the answer right now. But those are the nuances that we need to understand now that we have these agents that have demonstrated clear benefit in hormone receptor positive breast cancer.
And I'm sorry, did you say that there were ongoing studies, or none that you know of?
There are studies that are either being crafted or opening now, trying to answer these questions about whether you should either just continue, say it's palbociclib that someone had started. If they need a change in therapy, should you really stop palbociclib? Should you just keep going, right?
Right.
Just switch out the endocrine agent, or is there potential order, just like we have letrozole, anastrozole, and exemestane, right? All these different aromatase inhibitors. Well, now we've got palbociclib, ribociclib, and abemaciclib that are all CDK4/6 inhibitors. You know, they don't all work exactly the same, right? They're different drugs. Maybe we should be using them in sequence. We don't know that. And so those studies are happening.
So a trusted metastatic breast cancer advocate is saying that there seemed to be some excitement at San Antonio about an acupuncture study. Do you know anything about that?
I missed that presentation, but I did hear about it. I mean, I can say globally that there are clear benefits from acupuncture for either disease-related symptoms or managing toxicities, including like hot flashes from endocrine therapy. So I do think there is a clear role for these, adjunctive type interventions like acupuncture. And there periodically been presentations about the potential benefits, again, in all of these different settings. Just
looking through the last of the questions here.
These are great questions.
Yeah.
I wish I could talk to everybody.
And I'm sure they wish as well, but if we let that happen, you'll never get back to work this afternoon.
I'd prefer to do this.
So someone's asking, is Ibrance ever used in triple negative?
There are investigations about using the CDK4/6 inhibitors in the setting of hormone receptor negative, HER2 negative disease, because it's not specific to endocrine therapy. In fact, the initial trials looking at this class of drugs looked at all comers, and there was a signal benefit. So trying to understand, again, the right setting, and it's probably not just that drug by itself, but potentially paired with the right chemotherapy drug or other biologic agent may in fact be a place for it. So not a standard of care, but looking to try to get there.
And just a comment from a male patient that saying that he's applied for a number of clinical trials but has been turned down because he's male. So maybe we're hoping that you could put a word in some of the groups that you're associated with.
I absolutely will. And that speaks to the fact we have, so as we're developing this cohort, right, this collaborative group of investigators and clinicians in Europe and the United States focused on male breast cancer, we need to advertise that this exists so that our male breast cancer patients can find it. And the majority of people aren't treated in academic centers, but that doesn't mean you shouldn't have access to what's going on. So thank you for that comment, and I definitely will take it forward.
And I'll sneak in one last question. Do you believe, is alkaline phosphatase a good marker regarding progression of bone metastasis?
It is a marker that if you're going to look at it, needs to be taken into context with other factors. So the issue about alkaline phosphatase is that it's not specific to breast cancer or any cancer. And there are multiple sources of alkaline phosphatase, not just the bone. So there could be a reason for the other reason for that elevation that has nothing to do with the underlying breast cancer itself or the bones in general. And so it could be a red herring. So that's why we need these other liquid biopsy type markers to help use as a companion to imaging and symptoms and potentially alkaline phosphatase.
Thank you so much. I think that's all we have time for. Dr. Liu, thank you so much for your time. Thank you all for your participation. And I wanted to let you know about an upcoming program. We have an Ask Me Anything with the metastatic expert, Dr. Nancy Lin, coming up on Thursday, February 17th. It's through our online support, Health Unlocked. You can go on SHARE's website, sharecancersupport.org, and look at that. You can type questions to Dr. Lin. She will answer personal questions to the best of her ability. Dr. Liu, thank you so much for your time. We really appreciate it. Thank you, everyone, for participating, and we'll let you know when the recording is available. Thanks so much.
Thank you.
Thanks.